Ayodele, I think you can start.
Good afternoon, everyone. Welcome to today's webinar. Thank you for taking time out of your very busy schedule to honor our invitation. At this webinar, we are going to present the findings from our study, and we will be glad to receive feedback from you. But before we start, there's some housekeeping issues that I want to bring to your attention. Please submit your name, institutional affiliation, and the email address on the chat box. All participants will be muted, and we only be unmuted when you need to speak, and that will be during the discussion session. Please indicate by raising up your hands if you need to speak, and then submit your comments and questions to the chat box. Let me start by saying that the title of our presentation this afternoon is a Mpox as a public health emergency of international concern, preparedness, politics, and priorities. Next slide. The study was conducted by researchers from the Institute of Development Studies, UK, led by Professor Hali Maggo and her team. Dr. Said Abbas, Dr. Megan Smith-Sen, Mr. Tom Becker, Mr. Nathan Oxley, and the counterpart at the University of Ibadan, led by Professor Jegede and with Professor Kanin, Townsend, and Olufunke Adegoke as team members. We also have Dr. Michael Kuniji from University of Lagos. Next slide. This is the agenda for today's presentation. The presentation is the team effort, and each person as listed on the program will be presenting according to the order of presentation. Next slide. Next slide. On this slide, we can see that Mpox is not a new disease. As we all know, but its reemergence has taken a new dimension, raising public health concern. Globally, it is common among young men with a median age of 34 years, mostly commonly identified among gay, bisexual, and other men who have sex with men. It is most commonly reported, the most commonly reported mode of transmission are skin and mucosal contact during sexual activities. The African region has contributed significantly to deaths due to Mpox, with the highest number from Nigeria, as indicated on the table on the left-hand side of the slide. The mode of transmission is not yet clear, but the question is whether it could be that a mode of transmission in Africa could be a different reason. As for the epidemiological presentation, we see that the Mpox is a re-emerging disease, as we all know. Thank God the NCDC, we know that it's a re-emerging disease, and the NCDC declares its outbreak in 2017 in Nigeria. But the outbreak is in Europe in 2002, thus raised serious public health concern, with Lagos State accounting for the majority of the cases in Nigeria. Fortunately, the NCDC has risen to the challenge, leveraging the structure and facilities put in place during the COVID-19 pandemic. The study focused on understanding the multiple uncertainties surrounding Mpox transmission, pandemic preparedness, and ethics and justice debate issues, as listed on this slide. The methodology. It is an exploratory study with ethnography conducted between November 2002 and March 2023 in Oyo, Ogun, and Lagos State of Nigeria. Lagos State is in the southwestern part of, Oyo, Ogun, and Lagos State. They are all in the southwestern part of Nigeria. 84 in-depth interviews and 7 FGDs were conducted, in addition to observation for understanding the context and vulnerability to Mpox. We focus on Mpox. The attention is on human-to-human spread, primarily in urban areas, as we all know that the urban phenomenon is a new dimension in the spread of the disease. Semi-structured interviews were also conducted with policymakers, technical experts, and public health practitioners. Next slide. Our findings. Next slide on findings. Next slide on findings. Next slide.
Sorry, Ayodele, we just have a slide that won't advance. I'll do it in a second.
Okay.
Can we escape it and just advance it?
Stop sharing.
Okay. My apologies. Go ahead, Ayodele. Just a technical issue.
Yeah, thank you very much for getting it on. So the findings, let me, there are other slides on the findings, but I just present the first aspect of the findings. So the slide shows that cases have been highly heterogeneous with variations in experience, vulnerabilities, socioeconomic status, and age and gender profile. Dr. Adegoke, we talk more about this later. Mpox was most considered as a mild skin condition, similar to chickenpox. Those with severe symptoms were vulnerable for other reasons, such as people living with HIV, or older adults, persons, and so on. And there was a possibility of invisible cases, especially those that did not report at the clinic. So there were cases of co-infection and overlap, such as chickenpox and Mpox, HIV and Mpox. So the next slide does highlight the selected cases from the field. I will now turn the podium to my colleague, Dr. Adegoke, to continue.
Thank you, Professor Jagede. So this slide highlights research findings, which are heterogeneous cases from the study locations. The presentation cuts socioeconomic status. The slide also shows cases of the medium of contracting the viral infection, as well as the pathway of care seeking. For instance, on this slide, there are two separate identified cases from Oyo and Lagos states. Both are young adult males and are HIV positive. Now, one is a recovered case who's suspected to have been infected at his place of work, a lounge, and he embarked on self-medication using antibiotics. However, when his health condition got serious, he presented himself at the teaching hospital, where he treated himself through out-of-pocket expenses. Now, the other young man, who was a suspected case, stated he got infected from a gathering where another person was confirmed infected with Mpox. He patronized the chemist, used herbal medication of ginger and garlic, and did self-isolation. Also on the table, another was the case of a recovered 7-month-old baby whose mother stated got infected through her elder brother, a toddler who attended summer school. Now, due to the fact that she is a trained lab scientist, she diagnosed on her own through the internet what could be the ill health of her children. And based on her own internet findings, she visited a neighborhood pharmacy, informing the pharmacist of the drug she wants to buy. Finally, there was a suspected case of a pregnant woman who presented herself at the primary healthcare center. Her family members and residents in a landlord's compound were affected and all did self-medication. However, due to her own state of condition, being a pregnant woman, she refrained from self-medication. She later left the PHC without receiving any treatment, following instruction from her husband, when the PHC staff insisted on home visitation. Now, this last identified case reflects the effect of patriarchy, that is male domination in the Nigerian society. Next slide, please. Next slide.
Okay, Abbas is just going to share because we're having a technical problem on this computer. There we go. Wonderful. So
is it okay?
Yeah, perfect. So next
the
slide.
Next slide now. The next slide, please. Okay, thank you. Thank you. So as stated earlier, there are misconceptions that resulted in misadvice for the general population. And such was the case of Jane, who was a former sex worker and who has a son, and both are HIV positive. And she was vulnerable to more severe Mpox. Now, when she consulted with an elderly person in her neighborhood with regards to the rashes that actually appeared on her skin and that of her son, she was wrongly informed that it is chickenpox and advised to use bitter leaf and local dry gin called ogogoro. Now, this led to complications and both were admitted to the hospital. Of course, their hospital bills was paid by a known Samaritan since she could not afford the hospital expenses due to her own low socioeconomic status. I will now pass on to Dr. Kunuji. Thank you.
Thank you, Funke. The study included a component that focused on men who have sex with men, given the public health emergency of international concern focus. Although, as mentioned earlier, Mpox in Nigeria is more heterogeneous than in several other parts of the country, of the world. At the same time, it is important to emphasize that the legal environment in Nigeria and the same-sex marriage law, which criminalizes homosexual expressions, association, and assembly, which also fuels homophobia, may have resulted in many undocumented MSM Mpox infections. So given this, we worked with CSOs to interview gay, bisexual, and other MSM community members. Study participants felt that Mpox was very dangerous based on social media information. The data gathered also revealed varied levels of correct Mpox knowledge, ranging from very low to high knowledge among community members, and from average to very high knowledge among caregivers. The next slide, please. Few of the MSM interviewed linked their Mpox infection to sexual contact, and others to non-sexual social interactions within the MSM community still. Most of the MSM who were infected reported mild to moderate symptoms, but some, especially those living with HIV, had severe symptoms. For many of these participants with severe symptoms, recovery was a long process involving weeks of isolation with negative psychological effects. MSM typically reported that they benefited from support from CSO-run organizations providing services to the community, but many also expressed lack of support from the general MSM community due to stigma and discrimination within the community. Over to you, Megan.
Thank you, Michael. So we did a set of in-depth interviews at one CSO that experienced a small Mpox outbreak at their clinic. The CSO serves key populations specifically and is well equipped to provide a range of services for HIV and other STIs. Late last year, a patient turned up at the clinic with symptoms of unclear origin. One health worker was exposed and soon contracted Mpox. He had attended a meeting with other staff around the same time, and ultimately several staff members contracted the disease. The clinic had to close for a short period of time, and again later when other patients showed up with the same symptoms. This disrupted their provision of services, which are critical for many. The outbreak also had a long-term impact on staff and patients. In fact, the subject was too painful and several did not want to do an interview with us. The clinic does not have an isolation area nor the right resources to handle cases, but many staff would like access to vaccination so that health workers can protect themselves. So what does this experience mean practically and in context of our wider set of heterogeneous cases? More generally, the perception was that Mpox was a skin disease and was treated as such. Many called it chickenpox, as my colleagues said, and used either common home remedies like palm oil or purchased treatments like calamine lotion, antibiotics, or 7 Keys herbal tonic. Many Yoruba respondents shared that 7 Keys helps to, quote, bring the infection out of the body, and the lesions are actually a sign of healing. Otherwise, the disease would be stuck in the body and in the blood. Informal settlement residents, typically lower income, faced access barriers to primary healthcare facilities, instead choosing to seek care from herbalists who have many remedies for Mpox symptoms or drug shops. These are quick, easy to access, and offer a workable solution. MSM, in contrast, drawing on alarmist reports from social media, took a very aggressive route to treatment, purchasing antibiotics, vitamins, and other treatments. One patient took 4 antibiotics and 7 other types of vitamins and supportive care. MSM also placed a strong emphasis on trusted sources of care, as do others, but this included specifically the key population-friendly clinics that are a part of HIV care infrastructure. So what this means is that there is a complex patchwork of care providers for Mpox, and very few go to the formal public health sector, and so many are likely to be missed by the surveillance system, despite everyone's best efforts. Over to you, Abbas.
Thanks, Megan. Our last set of findings relate to the policy implications of Mpox and its response. So as we have seen, the Nigerian public health community was quick to declare an outbreak. An institution-wide ranging response was established really early on from 2017 onwards. However, this response was accompanied with lots of challenges at different levels of health systems functioning as well, which has impacted the quality of surveillance as well as the nature of response to Mpox in Nigeria. For instance, at the local government level, we have seen that there's a small number of disease surveillance and notification officers working at the local government level. They are overworked, overstretched, covering large populations, and often lack adequate resources for transporting patients or samples or themselves, which means they will have to likely prioritize between competing disease alerts. They also, given the fragmented nature of public health delivery services, they have to rely on a network of community informants to source a lot of disease alert information. And these informants have either more or less varying level of incentives and resources to find and report cases. At the state level, we noticed that there were some tensions with federal institutions over the resourcing, level of decentralizations, as well as protocols. For instance, given the experience with COVID, where a lot of expenses, a lot of resources were given by the federal agencies, there were expectations that PPE costs, treatment costs, admission costs for Mpox also might be sourced from federal agencies, which is not always the case. There's a lack of lab testing available at the state level, which led to delays and possibly reduce the quality of reporting and the quality of response to early Mpox cases. Sometimes these results are due to delay in transmitting samples to the NCDC lab in Abuja or lately in Lagos, and all of them impacted the quality of response. At the federal level, we do need to acknowledge the multiple and credible accomplishments of the newly established National Public Health Institution, which is the Nigerian CDC. They have achieved a lot, and they played a major role in making the role and visibility of public health accomplishments in Nigeria quite visible. It plays a prominent role in setting national priorities as well as interfacing with global health agencies. But at the same time, the NCDC also gets exposed to tensions between global versus national versus local priorities. For instance, in responding to Mpox as a public health emergency of international concern, that emerged quite late on in the Mpox outbreak at the global level. And at the same time, the prioritization for Mpox was in some ways going down in Nigeria while the cases were going up. Now the disease trends seem to have reversed. So NCDC has a different role to play in speaking in different voices to different audiences. Similarly, there appears to be different levels of prioritization around vaccinations and therapeutics among national and international health communities. Which leads us to the next finding, and then which leads in, and also recommendation, which is that the quality of response and the nature of response has to do a lot with long-term institutional strengthening in the Nigerian public health system. They have really good labs and really experienced public health professionals, but as we've seen in the case of Mpox, a lot of the resources were as a result of investments in polio surveillance mechanisms. A lot of reforms came about because of feedback from the Ebola response, and COVID also played a role in influencing the expectations and of different public health actors at multiple levels of functioning. Health being a state subject, the cost and quality of Mpox care differs by state, and again, different resourcing is available to different states. So I will invite Professor Jagede to make the next set of points about the institutional strengthening. Thank you.
Ayodele, you're muted. If you could just unmute.
Thank you, Dr. Abbas. The NCDC over the years has put in place an excellent model of disease surveillance and response, as earlier noted. However, this needs to be paired with longer-term health system strengthening, as we know that sustainability is an important strategy for sustaining the gains from whatever whatever we put in place. However, the fragmented governance and coordination and poor and inadequate human resources, as well as funding issues, have crippled the, let me say, affected the primary healthcare system, and this has resulted in the functioning of the PAC, leading to low morale of health workers who, from time to time, complain of lack of enough resources, especially basic, say for instance, transport money to do day-to-day activities. So the health system then does requires to pay attention to these areas. This being the last slide, I want to invite Professor Hali to for the next stage of the presentation.
Thank you. Thank you very much, Ayodele. We have invited discussants from the 3 states. Not all of them have been able to join, but I'm going to invite Professor Lowenson to introduce the discussants. We actually have just finished a whole set of feedback meetings with many people interviewed in the states, answering questions on our research. But if there are additional questions, please do put them also into the chat, and we can address them at the end of the panel. But I hand over now to Professor Lowenson.
Thank you. Thank you. The next is to hear from, are you hearing me, please? Hello?
Yes, Akani.
Oh,
yes.
All right. Okay. The next to hear from a group of discussants. We have representatives from the 3 states from where the field work took place as our discussant. I'll start with introducing Dr. Akim Yusuf, who happened to be the state epidemiologist for Ogun State in Ministry of Health. Dr. Akinfemi Akinyode, the state epidemiology for your state, Ministry of Health, and Dr. Christiana Odadipupo, who happened to the DSNO for the Mushin local government area of Lagos State. The three of them are going to be our discussant. Please, can you signify your presence on the platform? So I know I can see Dr. Yusuf Akim. Is Dr. Akim your day on? Hello, Dr. Oladipupo. Okay. Well, let me give. May I invite now, Dr. Can I invite you for Dr. Akim Yusuf for a brief remark on a brief response to our research, just for about 3 minutes, please. You have the floor. Dr. Akim Yusuf.
Thank you very much, Prof. And other members of the research team. I'm audible?
Yes, please.
All right, thank you very much. And I greet other members on the platform. It's a privilege to have been invited as a discussant on this very important topic. Ogun State was selected as one of the research sites, and we were glad to have the team to carry out the research. Very importantly was that we had cases in Ogun State. The first case of monkeypox was in 2021, and afterwards and that was just 2 cases for that year. And subsequently in 2022, we had significant number of cases, and coming to 2023, we are still seeing cases. And the response in 2022 was prompt, because sensitization, awareness, training has been brought up with support from partners by NCDC, that's the Nigerian Center for Disease Control. And just like you have rightly identified in your research, initially there was a reluctance from the cases to actually seek for care from the health facilities. Many go seek for self-care from different means, like you mentioned, some going to the patent medicine vendors, some going to self-medications for several reasons. But as awareness was created right from the national level, being brought down to the state level, we did an aggressive kind of sensitization where we conducted training across the secondary, the tertiary, secondary, and primary facility health workers to bring them updated in terms of what to look out for. Because most times when clinicians don't know what to look out for, they can't identify such cases. So we actually brought them up to date in terms of case identification, what to look out for to suspect monkeypox. That was done. And it wasn't stopped at that, because we know it's only cases that come to the health facilities, the health clinicians or the health workers would pick. So we took it down to the community level. We had a robust training and awareness creation among the group we call the community informants. These are part of our surveillance structure in case identification. So they were trained. These were members of the community that has eye contact with members of the community, either due to their personality or what they do. So just like the religious leaders, traditional birth attendants, even the patent medicine vendors that most of these cases would go and visit at their first point of contact. So we did a kind of robust sensitization there. So following this sensitization, we were able to start seeing increase in number of cases being reported. So that actually increased the number of cases. But surprisingly was that, yes, initially we decided to take them into isolation irrespective of their mode of presentation. But later on, there was this reluctance to be isolated because many of them presented with mild or little severity. So it was just basically because of the rash, the presentation of the rash that makes them feel they should come out to be attended to. They feel ashamed of what they have on their skin. Ordinarily, most of them don't have limitations in terms of their physical activity, strength. They can still go with by their daily activities, daily livelihood. So many of them actually rejected being isolated. So we have to, based on that psychology, we decided to also do like lesson learned from COVID, home-based care. So we identified those that could be isolated at home and let them do while we observe them using the closest health worker to visit and ensure that they take their medication, and subsequently they did fine. Another very surprising situation in Ogun State is that most of our cases, we were running the HIV test so as to be able to identify if they actually the key populations, but it wasn't, contrary to what we've read in publications, what has been reported in the Western world. We didn't have that picture. And also the picture in Ogun State, we have commonly the middle age group, youth and young adults. It wasn't really in the elderly. So we had that category. But people were actually willing to speak out, to seek for help, and were able to identify such significant number of cases across board. But we still know that what we
round up within the next 25 seconds, please.
Thank you. So what we're able to identify, I know, was still a tip of the iceberg from what is happening in the communities. Many still went unreported, and many still sought care from different, but sensitization was not left aside. We continued, and it's still very much ongoing. So I'm happy to hear from the feedback and the recommendations you have made from this research. Thank you very much.
Thank you. Thank you for the remark. May I invite Mrs. Christiana Oladipupo? Can I invite you to make a brief response to our research for about 3 minutes? Please kindly keep within that frame of time, please. Ms. Christiana Oladipupo, please.
All right. Good day, everyone. I don't know if everyone can hear me. It's raining heavily.
Yeah, we can
here.
hear you. We can hear you. You're
Okay.
audible.
We can hear you.
All right. My name is Christiana Oladipupo, and I'm very privileged to be part of this webinar. Yes. Concerning Mpox, when it started in Lagos, it was kind of new to people like me, because I've only read it in a book before I saw the first case. And because it's not something common, we had a lot of difficulties to even get that case, to the isolation center. Apparently, there were more cases within that very compound, involving a 4-month-old. So it was a big issue on our hand. The local government chairman had to come in, the MOHs, all the LGA team had to be involved. And from that time, we started creating awareness. We started sensitizing our community informants. Our community informants consist of TBAs, traditional healers, private patent medicine vendors, and community leaders. So we started sensitizing them, and then more cases were reported. Generally, I would say that for Mpox, yes, it's common among the people of low socioeconomic group, but like we have discussed earlier, the risk factor in all of our cases, we cannot pinpoint it to a particular source. And I also discovered that the incidence is higher during the dry season. We have more cases during the dry season, and a lot of the cases are underreported too. But by the time we start contact tracing, when they come like that, we take samples from them, we ask them, does anybody have this type of rash around you? Okay, we take a list of all their contacts, whether they are infected or not. We found out that there are many cases. Some will tell you that, Madam, don't bother, I don't want to come to the hospital, I can take care of myself, even when I offer to see them in the house. So some will still believe it, like measles, and because Mpox is self-limiting, most of the time it will wear off on its own if no complication sets in. I found out that generally a lot of the cases are there in the community, that yes, you get to know some of them through contact tracing, but there are a lot more that you would not even have idea about. And because of that, I would just recommend that the government should help to create more awareness. The government should help to create more awareness so that people can know more about it and see the need to report at the health facilities. that will also reduce how people patronize this herbal herb sellers, PNVs, for this infection. So I would like to stop here for now. Thank you very much.
Thank you so much. We appreciate your opinion, your brief on the research and response to it. Please, do we have Dr. Akifemi Akinyode on the platform?
Akani, I think Dr. Akinyode has been unable to join, so I think let's move on to the panel.
So let me then you can go on then, please.
Thank you. Thank you. Thank you very much, Akani, and thank you also very much to Dr. Yusuf and Dr. Christiana. Very much appreciated to get your sort of accounts really right from the coalface. So in the final 45 minutes, we want to have our panel discussion, and we have 6 very eminent panelists. So in the panel discussion, as I said, we've had a series of feedback meetings where we've really got very wonderful responses from people in Nigeria to the research findings. But in this panel, we really want to shift the focus to the wider implications of Mpox globally, Mpox having been declared a public health emergency of international concern. And we titled this webinar, Preparedness, Politics and Priorities. So we're asking our panelists really to reflect on these wider implications and particularly for pandemic preparedness going into the future. As you've heard, based on our findings, what has really come through is a very different experience of Mpox potentially in different regions. And in the light of those findings, we've identified a set of issues, and really in asking these questions, we're really wanting to deal with some issues. For example, what are the implications of these different contexts for how Mpox is also framed in different parts of the world? Given the heterogeneity in Nigeria, what are the implications, for example, of framing Mpox solely as a sexually transmitted infection? You've heard there's a more heterogeneous picture in Nigeria across age, gender, and social group. And we're thinking also about implications for responses in Nigeria. How should one then account for vulnerabilities, for example, amongst those who are HIV positive, but also how can responses avoid targeting particular groups as at risk and potentially having the unintended consequence of fueling stigma, given also the different and more tricky legal environment for men who have sex with men in Nigeria. And you heard from Michael about that. We feel this research also surfaces wider questions about global level responses and equity. For example, there's been no vaccine available in Nigeria in contrast to high-income countries, and we're really grateful to CSER for joining, because we feel it's important to surface or reflect on some of these wider ethical issues. Finally, we also suggest that there's a need to unpack discourses around different regional priorities. As you've heard, there has been quite significant mortality from Mpox in Nigeria, but there are, of course, other diseases that have higher mortality. And you heard in our presentation, we heard from our respondents about a sort of general disease, high disease burden, and people on the ground for surveillance and response really struggling to prioritize. But of course, this idea of having to prioritize in and of itself is underpinned by long-standing inequities globally in health systems linked to wider structural violence. So how do we really address this discourse around different priorities, and what does it mean for sort of connections between regional and global responses? Finally, there's a set of questions really about why global institutions didn't really take note of the uptick in cases in Nigeria in 2017. We don't know what the relationship between that is and the outbreak in non-endemic countries. But it does raise a question that was asked last year, in fact, by Chikwe Ekwezu, who's now at WHO Berlin, former Nigeria CDC. Why was that delay? Why was a public health emergency of international concern only called when cases were detected in Europe? So these were the kinds of issues we wanted to surface, which are sort of summarized in our 4 questions. And I'm going to introduce our panel. Akani is going to introduce our panel, and then I'm going to ask them to each make just short 3-minute reflections before we open up discussion, also to include the chat. So Akani, do you want to come in and just introduce our panelists?
Thank you very much, Ali. We have put together a 6-person panelist, and I'm happy to inform you that the 6 of them are present on the platform here now. I'll start with Dr. Chinwe Lucia Ochu, Director of Planning, Research and Statistics, Nigerian Center for Disease Control and Prevention. Professor Rosemary Audu, who happens to be the Director of Research, Nigerian Institute of Medical Research. Mr. Alex Ogudipe, the Director of Community Prevention and Care Services, National Agency for Control of AIDS, NACA, Abuja, Nigeria. Dr. Cesar Elimsia Atol, Department of Philosophy and Classic, University of Ghana. Dr. Jeremy Williams, Department of Science, Technology and Engineering and Public Policy, University College, London, UK. And Professor Melissa Lee, Director, Institute of Development Studies, UK. Let me now hand over to Professor McGregor and Professor Jegede to moderate the discussion of the panelists. Thank you.
Thank you very much, Akani. So if our 6 panelists could put on their videos, I would be grateful. And I'm going to invite them in this order, just to offer very brief initial reflections to get our discussion going. So Dr. Ochu, could you unmute and just offer your reflections on some of these questions or other issues you would like to raise?
Thank you very much, Heli, and good day, everyone from different parts of the world that are part of this webinar. A big congratulations to the research team for a wonderful outing. It was really a pleasure listening to the presentation of your findings. These are a lot of questions, Heli, I must say, and it will be difficult to really address all of them in 3 minutes. But I think there are key things that are coming out, both from the questions and from the presentations we have all listened to. The importance of preparedness as a global community, the importance of the whole world working closely to prepare, to build our health security, global health security, and also the need for contextualism in preparedness and response. We've seen the heterogeneity and the diversities in both the way Mpox presented in different parts of the world. We've also seen the political factors that influenced the designation of Mpox as a public health emergency of international concern. What you rightly pointed out, this not being declared until it became a global health problem. Our ability as a scientific community to identify which pathogen has the potential of being a global health problem is very key in our preparedness efforts. There is need to invest in research and development on infectious diseases, both novel ones and the ones that are already causing outbreaks in different parts of the world, and to also invest on ability, research on those tools that will help us to quickly detect and respond to these disease outbreaks. Investing in research and development of medical countermeasures, diagnostics, vaccines, and therapeutics, very, very key. And this must happen even before it becomes a widely spread problem. Mpox is a very good example that is teaching the whole global health community a very big lesson, that what happens in one part of the world should not be ignored, but should receive that global attention to determine whether it has the potential of spread, and then of course to even build capacity within that local space, be able to detect and respond to these disease outbreaks so that they don't become a global problem. So that is very key. The importance of engagement of local communities in addressing their health issues is important. I was really excited when I was listening to the DSNOs present, and this is one beautiful thing that I love about this research group, that you did not come to research on us, but you came to research with us. So it's like working with local communities to define research questions, develop their own research agenda, list their own priorities, and then working closely with them to address those questions. This also brings to point the importance of equity in such partnerships, so that we're able to work closely together as partners, experts working with lay, working with community influencers. We have seen the beautiful role that these ones played in this particular study. So working with them to develop research agenda, to implement them, and to evaluate the response. Also, what is coming out here is the importance of One Health, multi-sectoral approach, working closely with different teams in defining, building these structures, strengthening systems, surveillance systems, etc. Another thing before I stop, that we find recurring in most of the reports from the research is the issue of healthcare and how people have access to healthcare. The issue of lack of universal health coverage, where people are now self-medicating, doing out-of-pocket payment, and because of poverty, they are not able to access healthcare. So it is important that both national governments and the global health communities will work towards the achievement of universal health coverage by strengthening primary healthcare and making sure that people have access to care, because this also predisposes us to the danger of antimicrobial resistance. You see, there are a lot of people already taking antibiotics even before seeking care. So there is a global pandemic that is awaiting us, the antimicrobial resistance, and not doing one thing, not taking care of one end of the spectrum is going to lead to a more catastrophic event in the future. So let me pause here, and then we can address more things as the questions come in. Thank you.
Thank you very much, Dr. Ochu. Wonderful insights there. Could I invite Dr. Udu, Dr. Rosemary Udu, could you put on your camera and offer your remarks?
Let me thank the organizers of this webinar for inviting me to this as a panelist. The presentations were quite interesting, but one thing that I know is that prevention indeed is better than cure, because as for pandemics, we'll keep having them. It's just when the next one will be. So talking about ways that we can prepare for the next pandemic, I will just mention a few things, particularly as it has to do with research where I work. The first one is to monitor zoonosis. You know, WHO has already identified some priority diseases, but I think that each country should also identify priority diseases. And I guess that also comes into play in talking about priorities. You know, whether Mpox is a priority is something that a country will necessarily have to define itself. But we need to monitor zoonosis. Like in the Nigerian Institute of Medical Research, for instance, we have some projects we're doing that we have staff on the field where they are going out collecting samples from rodents, from mosquitoes, bats, ticks, and all of that. We're looking for these viruses. Because of the closeness, the relationship between the humans and these animals now, we are having a lot of zoonotic infections and even the climatic change also. So we necessarily need to do that. We don't have to be just reactive. When there is an outbreak, we just go there and try to stop it. We, from our own side, is just being proactive. monitoring where are these viruses, and so we'll inform the community once we find them. And then the next is sequencing globally. Prior to this time, in fact, it's been like most sequences were done in the developed world. The story was quite expensive, and so you just pull samples and ship them out for them to be sequenced. But now it's important that we really know what we are fighting. We need to develop tools to tackle pandemic. We need, like, the sequencing will be good for us to know, to help with the diagnostics, with vaccines, therapeutics, and that will help us know what we are fighting. And so as we are even finding these viruses, we need to sequence them. So capacity for sequencing should be developed everywhere. I think every country should have that capacity to sequence, because it tells us a lot. It tells us about the transmission. It tells us about the virulence. It just helps us to understand the characteristics of these pathogens better. So globally, we necessarily have to strengthen the capacity for sequencing. It shouldn't just be limited to some areas. And then also we necessarily need to strengthen manufacturing. You recall that during the COVID-19, we had this lockdown. We could not even get a number of the things, the supplies we needed, because everything was imported and what have you. And since there was this lockdown globally, it was quite difficult. So I think nations and regions should begin to strengthen the capacity to manufacture some basic things, and then including things like vaccines. Of course, we do know that we had this vaccine inequality, and we necessarily have to avoid that. And the way to do that is to strengthen the capacity to manufacture, even if it's regional hubs that we have that will help us to have these vaccines. Right now, we're even talking about Mpox. I do not know if we even have the drugs available in country. You see, so that's one of the things that will even discourage people from going to the hospital, because we really don't have the drugs. So what exactly are they going to give to them is what some people will say, aside from the fact that they will isolate those with severe symptoms. So they must know that there is something that we can offer them in these facilities, in the hospitals, for them to come. All right, so we necessarily have to strengthen the capacity to manufacture. And then we need to also prepare vaccines for rapid production. So these things are actually linked. We need to be able to produce, prepare to produce vaccines for rapid production once there is a need for it. Okay, it's not just when it appears before we begin to look for where to get it. And because we do know that vaccination is essential to beating viral pandemics. Then the last thing that I'll mention is to stop the spread. And stopping this spread is very essential. And that's why the local government areas, the local communities necessarily have to be strengthened. They really have to be strengthened, because they are the ones that see more of the cases. So from this research, I have seen that it's more of the national is really very strong. NCDC is doing great. And then it thins out, the capacity thins out from the state down to the local government area. So we necessarily have to go together, because in responding to pandemics, the weakest point is where we are going to have challenges. So we necessarily have to strengthen all areas. And so we need to find ways to delay spread of the virus, okay, to prevent, using especially the non-pharmaceutical means, as we saw in the case of COVID-19. And so we necessarily have to work with the local communities. And then I think just these few points, I think it will help us in preparing for pandemics. I thank you.
Thank you so much. A very clear articulation of the sort of prevention, One Health reminder of that element of preparedness. Thank you very much, Dr. Udu. we've had quite a bit of engagement with the National Agency for the Control of AIDS, and I know Dr. Alex has been trying to connect this morning, but I see he hasn't been successful. Kani, I know you're in touch with him on the phone, so I'm going to move on to Cesar Toure, but maybe you can try and see if you can facilitate Dr. Alex joining us, that NACA perspective being so important.
He was in sometimes.
He's probably having connection difficulty. Well, let's hope he manages to join. Thank you, Akani. But can I invite Cesar, if you could offer your remarks?
Well, thank you very much for inviting me, and this has been very informative and very interesting. I might say I feel a little bit like a fish outside water, because I mean, most of the speakers are either people in public health directly or in medicine. And I mean, so I'll take this more from, my perspective, which is a health ethicist philosophy. And I think what monkeypox has revealed is, one, the first thing, we have a knowledge gap. That is very important. But this knowledge gap is actually based on an epistemic limitation. So we have a disease that in Europe and in the Americas is principally a sexually transmitted disease. In the rural communities, for example, in Cameroon, where monkeypox is also present in rural communities, we have a disease that is linked to people who live in contact with wildlife. In the urban communities, we have people who interact closely, also falling sick from Mpox. Now, our scientific approach is such that we tend to classify diseases by the type of virus or by the type of bacteria. But really, is this the same disease? Is this the same illness? Is the lived experience of the person who falls ill the same? And so if we keep looking at diseases only from the viewpoint of a virus, we might run the risk of missing certain essential points. And this calls for a broader interdisciplinary approach to diseases and pandemics, which means that we need to bring in the social sciences, anthropology, and all these sciences so that we can understand the disease better. That is one. Second, because of the nature of the disease, we have issues of intersectionality. So the health-seeking behaviors of people differ. And I find it very interesting that, a lot came out in the research and also in the presentations that people tend to self-medicate, people tend to hide, and so our cases are undetected. The issue is that across Africa, most of our health systems are still suffering from the residue of colonialism. And therefore, we create our national health systems in a way that competes even with the traditional health systems, instead of working with them. If this is where people go, we have to take our healthcare there and not ask them to come to us. And there's something that is often very missing, especially for us as professionals and people who are, in Africa and in Europe, is this. As we're sitting down on this webinar, speaking away, our salaries are not being deducted. We haven't stopped earning. But if you are a subsistent worker, the moment you stop working, you stop earning. And therefore, you will go for healthcare at the nearest place where you can get a quick fix so that you can get back to work. This is important. And if we continue to think that we can take people to structures, to healthcare facilities, for them to lose half a day in order to resolve something that they can go around the corner and get somebody to give them a quick fix and get them back to work, we will fail. Then, our public health, policies, we really need to visit them because COVID actually taught us. Lockdowns don't work, isolation centers don't work. And at the beginning of the Mpox outbreak in parts of Nigeria, they were banning bushmeat. what is the livelihood implication of such a policy? So we need to work with our people and really engage with them and use what we have, and not only even expect help from the West or from the Europe or from North, whatever term you want to use it. There are already existing systems and we need to study them. And that is why we need to reframe our understanding from an epistemic viewpoint. And so we can draw on these resources, because if we're going to rely on the international community, we will fail, and we failed several times. The most effective vaccine for Mpox is not going to be enough to spread, to reach Africa, because I'm not going to mention the name of the country, but the country has already a pre-buying agreement that has taken up all the stocks. So, I mean, we can't even hope for it for now, unless they finish taking care of their needs and they want to donate it to us. So we need to look in. And since the time is limited, maybe just one point. You see, the last point is also with regard to the victimization. I mean, Mpox has been around for about 50 years in Central and West Africa. It has never been a sexually transmitted disease as seen as such. Now we live in countries where it is actually illegal to practice homosexuality because of the legal system in our countries. And the more we begin to, portray Mpox as a sexually transmitted disease between men, particularly between men who have sex with men, even when we have the resources, it's going to be difficult to be able to allocate. Are we going to come into Ghana or Nigeria or Cameroon and say, okay, men who have sex with men, you come first, we're going to give you the vaccine? We're going to be exposing people like that. And that is why we really need to rethink our approach and even the way we communicate about this disease and have a broader approach to the disease. So just to sum up, we need to revisit our epistemic framing. We need to take an intersectional lens to analyze this. And we need to take a decolonial approach, which means that we have to start drawing from the resources we have within country. I'll end here. Thank you.
Isa, thank you so much. That was incredibly insightful and beautifully put. And that's precisely why we need more than a public health view. So thank you very much for being our ethicist on the panel. Jeremy Williams from IPPO. Jeremy has led the UK ESRC funded research, a very different context. And I'm so grateful to you for being willing to just reflect a bit that difference from your research. Please go ahead.
Yeah, thank you, Haley. Great to be here, and congratulations on this piece of work. I think we here at IPPO, which is the International Public Policy Observatory, we produced a piece of work on the recent outbreak in the West, which I put a link in the chat, but I don't know if everyone has access to the chat, but if maybe IDS people could share that with them, that'd be great. You can download the report. And it's good to hear the last speaker talking about the social science issues. We were focused on social science issues related to the outbreak. Largely in the UK, we also spoke to people in the US, Germany, and Spain, so focused largely in the West. But I think there's some synergy in the findings, particularly around, I think, the fifth finding from your work around long-term institutional strengthening. That was one of the key things we came up with in terms of our work, which was success often didn't depend on response, it depended on existing infrastructure that had been built up over time. We came to this finding through speaking to various people involved with response, the third sector, or through sexual health clinics, who are often at the forefront in the UK and in the West. Also, we spoke to clinicians, those treating people, those with lived experience of Mpox as well, to get the impressions of people on the ground, as well as policymakers, those grappling with responding to the outbreak in a strategic way, be that working in healthcare or indeed in governments. So I'll talk briefly through, I guess, our key top-line takeaways and how they relate to this project. Existing infrastructure was key, and by that we don't just mean things like healthcare clinics, we also mean things like social infrastructure. I know one of the discussion questions was around the question of lessons from COVID. We often found in the West that the lessons were actually the HIV crisis of the 1980s provide some of the, I guess, the learning background to the way in which Mpox responded to in sexual health clinics and amongst the men who are sexually offended community. And I guess the The policy recommendation, as we try to make policy recommendations for our research to make it usable, from that would be to appropriately resource this infrastructure now. So success doesn't just depend on jumping into action when an outbreak happens, be it event or something else. It depends on putting resource into things like sexual health clinics and holistically appreciating the role of frontline responders, third sector sexual health clinics, et cetera, as that then will allow for success going forward in terms of responding, not just to Mpox, but to other known unknowns, unknown unknowns in terms of things like that. We also had some findings around the importance of messaging, particularly around co-producing messaging. Co-producing messaging with affected communities we found was the most effective way of getting the message across about things like vaccines, as well as ideas around prevention, sharing information around symptoms and how to get treatment and that kind of thing. And the idea of having a feedback loop is important, that those in charge of messaging are in constant contact with people on the ground. So there's an ability, therefore, to have a constant of updating the situation, it not being a sort of megaphone at people, it being something more symbiotic. We also discussed hard to reach groups and the importance of targeting hard to reach groups, particularly those who do not engage in things like social media, which is one of our areas of focus. As well, the idea of having collaboration as well, it not being this top-down idea that you have leadership which is spread across various levels and fostering collaboration between people on the ground, organizations on the ground, and people in charge. And finally, there being a mechanism for lessons learned from previous outbreaks. Like I said, the lessons from the HIV crisis of the 1980s, I think, were often applied by those on the ground. We didn't feel the lessons from COVID were applied. So I think particularly as cases, thankfully, in the West are quite low, they may rebound Mpox in the summer, but having a mechanism for the lessons from the last outbreak to be learned, so which we have contained in the report, I think is key in terms of going forward. So yeah, congratulations again for the report, and looking forward to hearing everyone's contributions.
Thank you very much, Jeremy. I know from having heard your findings, you also, in fact, reflected on that problem of the unintended consequence of stigmatization from direct interventions. And I think that's probably very relevant as well, but wonderful. Thank you. So finally, I'm going to invite Melissa Leach, who has led for many years now work on pandemic preparedness. So we're very grateful to her for being willing to offer.
Well, thank you for the opportunity to offer some reflections. I mean, I don't do it as somebody who's either worked directly in Nigeria or on Mpox, but more from a wider perspective of having reflected on quite hard the global and regional politics at play in a world which is increasingly concerned about pandemics, pandemic preparedness, and is building up to this global pandemics treaty next year in the wake of COVID and other outbreaks. And there are sort of three reflections I want to offer, which are all about politics and power. One is about prioritization, one is about inequities, and the third is about knowledge or epistemic politics, as Caesar said. And they're all areas where I think Mpox really causes us to think much harder about some of these political issues. So the first then, around prioritization, as we've heard, at a global scale, Mpox was only recognized really as a problem, only came into this global view once it was affecting the global north. And even now, we find that globally, global discourses are often framing it as less of a priority in African settings, such as Nigeria, as compared with the global north, partly because those African settings are seen to have so many other priorities. The idea that Mpox is not a priority, perhaps because the number of deaths has been relatively few. But I think that's a problematic framing, because as this study has shown, if we disaggregate, there are a significant number of people in Nigeria and in other African settings who do have Mpox, who do need care. There are some who experience severe disease. And that Mpox is sitting alongside and intersecting with so many other priorities, other skin conditions, HIV, other conditions that are compromising people's immune systems, isn't a reason to ignore it. it's actually a reason to take note of those other health conditions and the fact that they are so many and so difficult. Maybe you don't notice Mpox so much if you're suffering every day from a variety of other skin conditions, but that is not something that the global community should ignore and frame out of view in a discourse of prioritization. So often, this framing around prioritization masks and depoliticizes these realities of the health conditions out regionally. So my second reflection is that these realities, some of those we've been hearing about today, are actually reflections of really quite deep and long-standing inequities in global health. So there are, of course, short-term inequities, as we've been hearing about today. Which countries get access to scarce vaccines, which countries get access to scarce drugs, which countries have the economic resources to be able to purchase those drugs and make them available on global markets, or where are the resources for necessary Mpox communications and care to support the kinds of efforts of the institutions we've been hearing about in Nigeria. There are inequities in resources in the short term. But there are also deeper, longer-term inequities in the strength of health systems, health inequalities that in turn reflect inequalities in nutrition, in livelihood, in economy. These are deep-rooted. They often reflect colonial legacies. They reflect deeply unequal global political economies. So some of the things we've been hearing about today as risk factors for Mpox, immunocompromisation, co-infections, low socioeconomic status, crowded living conditions, crowded working conditions, are and should be thought about as products of these long-term inequities. And one might reflect that a global framing and action around Mpox needs to recognize and address these as part of striving for greater equity in pandemic preparedness and global health. And finally, and to pick up a little bit on what Cesar said, I think this webinar tells us some important things about knowledge and the politics of knowledge and indeed of global health research. Because as this research has shown, understanding people's lived experiences of Mpox, which in turn are important to understanding transmission and to impacts and to implications, needs not just epidemiology, public health sciences, biomedicine, but it needs social science. It needs not just globally driven and conducted science, but that which engages with the local knowledge and experiences and treatment seeking of people themselves, understanding their diverse lived experiences, and through the kinds of equitable partnerships which are about working with people, not on them, as somebody so nicely put it, in partnerships, knowledge partnerships that are truly equitable. And surfacing and validating local and regional knowledge and perspectives and supporting them is, I think, a third leg of this shift in the politics around global health. So a politics of knowledge, a politics that recognizes and acts on inequities, and a politics that deals with prioritization properly as a political matter are, I think, some of the things we can learn from and take forward from the Mpox experience.
Thank you very much, Melissa, and indeed to all our panelists for just a really powerful set of remarks. I think so good to be reminded of these colonial legacies and long-standing inequities that are playing out now in inequities, for example, in global vaccine production. But I also really valued from Dr. Ochu and Dr. Udu this real stress on system strengthening. Dr. Udu spoke about laboratories, but you both also talked about universal health coverage and those problems created by the cost of care, which we really found in this Mpox work, people having to seek care elsewhere, and also talking importantly about that One Health perspective, but also the unintended consequences of responses around, for example, bushmeat that have livelihood consequences. So really many ways you've raised a whole new set of questions around rethinking pandemic preparedness. So thank goodness there is the process of the pandemic treaty, and one does hope that these interdisciplinary perspectives will feed in. I don't think we have managed to get Dr. Alex a connection to be able to join, which is unfortunate, but we're very grateful to NACA for many useful insights they played into our research. I'm just looking on the chat. We have one question, in fact, goes to this point about NACA, the AIDS HIV connection, and a comment from James Anani saying we need to know about the relationship between Mpox and HIV. There's a need for very robust awareness creation, especially in the target population. And thank you, James. James is from NACA, so we're very grateful to you providing the NACA perspective. I guess, James, part of the conundrum is, I know you have, as we've heard from NACA, such fantastic services for HIV key populations, your one-stop shops, but there is this concern about unintended consequences of targeted Mpox interventions, and we've had very useful discussions with NACA about that. And so thank you very much for that remark. Please, and we have another remark from Collins Adayanju saying, I think understanding the social and behavioral components of Mpox transmission as a public health emergency is key to addressing potential outbreaks, and this would help to inform communication. I think, as we've had in discussions with Dr. Ochu and other people we engaged with, there are a lot of priorities for research that NCDC in particular is really getting onto, and studies in molecular genetics and social epidemiology to really try and unpack some of those dynamics. I'm going to just invite again my co-lead, Professor Ayodele Jegede, if he has any specific comment or question to the panel. Ayodele?
Well, thank you, Holly, for the comments and the observation from the panel. I think the key issues have been mentioned, and that is the integration of approach, and I mean, making the preparedness not just to be an isolated, but kind of a approach that we run with other systems, so that there'll be sustainability and then there'll be continuity in the program. And also the political aspect is very important, not just about political will, but about political action taken to make sure that programs are well implemented, because where there are no resources, especially from within, it will be difficult to rely on donor agencies, and that, I guess, that is the challenge of the public health system generally within the African countries. So I think the panelists have actually given a good insight to the new directions that we can also set our eyes for other studies. Thank you.
Thank you. And the study has hugely benefited from a deep knowledge Ayodele has around primary healthcare in Nigeria, and a strong feeling he has about that need for primary healthcare strengthening primarily. And I guess this is this important aspect of preparedness that's often forgotten in the focus on vaccines and technologies. So thank you, Ayodele. We have 3 minutes to go, and we have a couple more comments also from oh, thank you, Greg Ashafur again from NACA. From the HIV perspective, contact tracing and leveraging on the community structures for case detection is important and key. Also, the need to strengthen the monitoring system. Yeah, Dr. Ashafur is really working on trying to unpack further the HIV vulnerabilities in Nigeria. And there's a question also for Dr. Ochu, and maybe we can make this our last question, Dr. Ochu, a question about what lessons you would like the global health community to learn from the NCDC's experience of and response to Mpox. I'd be very grateful if we could finish with your word on that. Very important question.
Thank you very much, Megan, and thanks everyone. This has been a very beautiful session. Yes, NCDC, like all of us have noted, had been responding to the reemergence of Mpox since 2017. And we have been using the same incident management structure that we use for other infectious disease outbreaks. And this was what actually gave us a leverage to even respond to COVID-19. So we have a multi-sectoral collaborating platform which utilizes an incident management structure with different pillars of response for preparedness and development of guidelines and of course deployment to respond. So the one key lesson that the global health community needs to learn from our experience is that internal structures, surveillance structures is key. And that structure has to go down to the very primary level, from community to local government to state and then to national. So digital surveillance has been very important. For us, we have a digital tool that we call the SOMAS that enables real-time data collection from the point of detection to the national level. It is partnerships is also another key lesson, that we need to strengthen partnerships, both local partnerships and international partnerships, especially local ones. We've been talking a lot about decolonizing health and all the, I think we need to start from ourselves. We need to stop working in silos and work closely together. So having that platform where you're able to engage different sectors and different disciplines, different people to come together to plan is important. And let me also emphasize here that engagement of community voices is also very key. These are the people that are usually left out when it comes to development of policies and guidelines. So if we have these platforms, we need to make sure that the right persons are there, and even the people that are affected by the disease are also part of the decision-making process. Look at infodemics and everything. When people don't participate in policy planning and development, there is lack of trust and there is lack of ownership. So it becomes very difficult. You don't understand their perspectives. What you think is their problem may not necessarily be their problem. It's also important to know that as a national community, we have our priorities. We have our local priorities that we want to really focus on. And trying to impose a narrative, a global narrative, to a local context will not work. It could be a sexually transmitted disease in another context, but that might not be our own, that might not be telling our own story. So we need, as individuals and as communities and as a nation, to investigate our own problems, understand what is the root and what can address, how we can address it collectively. We cannot continue to wait for the external community or the international community to come and solve our own problems for us. That is one big lesson we need to learn as a national stakeholders in national public health. So these are, of course, investing in local development. I think Professor Aldo mentioned this, local development of drugs, vaccines, and diagnostics. We want to be able to have point-of-care diagnostic for monkeypox or for Mpox that will help us to detect more cases. Strengthening our surveillance system for COVID enable detection of more cases of Mpox. We saw that gradual rise, in number of cases that peaked at 2022. It was because of the surveillance system that was strengthened across different parts of the country. So those areas that are not reporting now may actually have cases they are harboring. If we have point-of-care diagnostics that can quickly detect these cases, we will improve surveillance, we will improve control of these diseases. So there are a lot of beautiful lessons that I believe as a local public health community we can give to the entire world. Sorry, before I forget. I'm speaking here now because of my role in research, that what we would like as a country to see is that we have our own research agenda on these disease areas with our own defined priorities, and that partners, international partners and funders will align their interests to these priorities. It is very, very important that this happens, and I think I'm happy that it's happening with Mpox. We've been able to develop a research agenda, and it has to be inclusive when we are developing it so that everybody feels this is their own. And then partners that want to work with us on Mpox must align their interests to the priorities of the country. That is the only way it will work. And thank you, everyone. Congrats again for a very beautiful study and a beautiful webinar.
Thank you for perfect closing remarks. Thank you, Dr. Ochu. So I just want to thank the team, my co-lead, Professor Jegede, and our wider team, and also our discussants and panelists. And finally, just to say the recording of the webinar will be made available and will be sent out. We also have other outputs produced. We have a comic for a different kind of audience telling the story of Mpox, as well as a photo story, and those will be going out next week as well on our social media channels. So thank you very much to all of you for joining, and if anybody would like to write to us bilaterally, I will put our details in the chat. Thank you, everybody.
Thanks, Ellie. Great moderation.
Thank you. Thank you.